Hey, Dr. Mike here. So are you navigating the menopause maze? Well, we have a special guest that's going to help you get through it.
You're listening to Live Foreverish, a show dedicated to helping you live just a little longer. Here's your hosts, Dr. Mike and Dr. Crystal Gossard.
All right, welcome to Live Foreverish. Dr. Michelle Lapeoker. There she is. She is the menopause maze specialist. She's going to help us get through the menopause maze if that's something you're going through. Welcome to the show.
Thank you. Thank you for having me.
Board certified OBGYN, right?
Yes.
Been practicing in South Florida since 1995.
Yes.
And we found out it's pretty close to Dr. Crystal, right?
Right around the corner. I could walk to my appointments. You don't know how excited I am.
You got it.
Yeah.
I'll get you top on the waiting list.
All right.
For me, I'm really excited to have you on because, menopause continues to trend. Like in the Google, we call it the Google land, all that. And there's so many products now. There's so much information, even some misinformation.
Yeah.
So to have someone like you come on and you just bring it back to the basics. Let's lay a good foundation today for the audience that's listening about menopause.
Okay,
So
I'm ready.
So we're gonna start. I'm gonna start off the questions you got. I'm gonna start with a different question.
Okay.
Because I just want to.
Let me just add something too, just to kind of set the stage on how important it is for us to have someone, a gynecologist, OBGYN, because you're the first person that women will see typically that has any kind of training on this. And, you find a lot of hormone doctors, hormone specialists out there, and they may not have received the training that you receive, and you're seeing so many women. And so I'm just happy to have you on because of your unique expertise.
Thank you.
On the front lines.
On the front line. So speaking of being on the front line, when you see a patient, tell us a little bit about how you approach menopause in your patients. Like, what's your style?
Okay, well, I guess there's two types of patients that will come in. First, we have the woman that is coming in for her annual wellness exam. And whether she asks me or not, if I feel that she's in the age bracket where she should start to think about things, also given what we see in our social media now and in our conversations every day, I bring things up. How are you feeling? Are you experiencing this? The second patient is someone who specifically comes in and says, I want to talk about menopause.
Right.
I think I'm going through the changes. I have questions. Check my hormones.
Right.
Yes.
So there's two types of patients.
Well, let's get some definitions down now, right? Because what also is trending is this idea of perimenopause.
Yes.
So let's lay out the difference there, right? So you got perimenopause versus menopause. How do you distinguish those two?
So I've really embraced that whole concept. It's been pretty easy because, like you had mentioned, I've been doing this for many years now, and my practice is more focused on gynecology problems as opposed to the obstetrical division of OBGYN. So the rough definition of perimenopause is really from age 40 to 50, as far as having some black and white boundaries of when it happens, quote unquote. And I'll explain what that means. Okay. But perimenopause is roughly the 10 years before menopause. Since the average age of menopause is 51, then we talk about being in menopause or post-menopause after that point. But how do we know? Well, the definition of menopause is a woman who has not had a menstrual cycle for 12 months in this age bracket. Now, a young lady who's 20 years old without a period for 12 months, we're going to address differently.
Right.
We may not call her menopause right off the bat. But when we're talking about this age bracket, 51.3 years is I think, the exact number of average for a woman who will be entering the postmenopausal phase. So perimenopause is before that. Can it reach prior to 40? Yes. So it's the time frame in a woman's life before her period stops completely, where she is experiencing fluctuations in her menstrual cycle and in her well-being. For example, she may be experiencing trouble sleeping, hot flashes, missed cycles, more significant PMS, just for an example.
So would you start off with, I guess, the questions that you would ask, let's say that 40 to 50-year-old who's not really asking questions about it, but maybe you're thinking, okay, I know that perimenopause is a thing. What are those questions that you ask? Like do you ask about fluctuations in the cycle, or is it very kind of general, like, how are you sleeping? Kind of this incognito way, because you don't want to say, hey, you're at the perimenopausal age. I'm going to ask you a few questions.
Yes, that's a good point. We don't want to point it out that women are getting, aging.
We're getting older.
Yeah.
So
you're older now.
But one of the top questions is, of course, how are your menstrual cycles? Are they regular? Are you skipping? Are they longer? Are they shorter? I do ask about sleep. I think sleep's a big issue. I think most, again, 20s and 30s, we don't think about sleep much. But then all of a sudden it starts to become a little bit of an issue. So I do ask about sleep. I ask about vaginal health, mood changes, energy fatigue.
Wow.
Things like that. Yeah.
And then, so are there any tests that can tell you that you are in perimenopause? And then what about menopause?
Yes. So many patients come in. Check my hormones. I'm happy to do blood work.
Also
At this point,
too.
it's making everybody happy to do it. Does it really define the stage you're in? If a woman has not had a cycle, again, let's say 40s, 50s, a 20-year span, they haven't had a cycle for 12 months. They are having many symptoms of menopause or the changes. I think lab work is absolutely appropriate because, yes, an elevated FSH coupled with 12 months of no cycles does pretty much confirm a woman is in the menopausal state. Whether you call it in menopause or postmenopause, I think those are semantics.
Can you describe FSH for the audience, though, what that is?
A little, sure. Yeah. For basic understanding, it is a hormone that is made in our brain, in our pituitary gland. It is pumped out, and it sends a message to the ovary to make estrogen. Well, it's a negative feedback system. So when the ovary makes estrogen, FSH declines because it's happy. The ovary's behaving.
Yeah, you're behaving right, so I can calm down.
When the ovary is kaput
struggling
and there's nothing coming out, the FSH gets elevated.
Right.
Now, the little caveat to that is during our menstrual cycle, these numbers fluctuate naturally.
Right.
So you cannot really hang your hat on one number.
Okay.
And that's why when women in the quote unquote perimenopausal time want their hormones checked, I have to just remind them it's a moment in time. But I don't only check the sex hormones per se, progesterone, estrogen, testosterone, FSH. I look at vitamin D. I look at thyroid hormones.
Good, yep.
Because these all contribute to how a woman feels. And it's not uncommon, again, as we get older, for these numbers to change.
Yeah, that's such a good point, because maybe if you're having low energy or some of your symptoms, maybe it is your thyroid. Like you automatically think I'm in perimenopause, and it could be something else.
Thyroid is very closely, an abnormal thyroid situation can absolutely contribute to menstrual irregularity. And that we can even see in our 20s.
So with women in perimenopause, let's stick there for a sec, right? And you're doing some lab work, you're looking at some hormones. Is there a pattern? Is there a relationship between estrogen maybe dropping, progesterone changing? Do you see that kind of stuff going on?
I do. But again, it's a moment in time.
Yeah.
So, for example, if a woman in her, let's just say mid-40s, is having this little span of 2 to 3 months of no cycles, and we check her hormones during that cycle, they may look menopausal. However, 2 months later, she can get a period and boom.
And
she can get pregnant.
Yeah.
I mean, the hormones can flood right back to normal zone.
Yeah.
And then
Years ago,
we start all over?
Years ago, and I don't think you hear it as much anymore, was this concept of estrogen dominance during perimenopause, meaning estrogen is probably fluctuating a little bit, but there was this idea during perimenopause where a lot of the cycles were anovulatory. There was no really egg being produced, which means there was really no progesterone being produced. So you had this situation where progesterone the theory was low, and estrogen, even if it was normal, it's kind of dominant because there's no progesterone to balance it. Is that a concept that you think drives a lot of symptoms now, or is that really not discussed anymore?
So you really hit the nail on the head with that whole concept. And I do explain to women, I don't use the word estrogen dominance, but I do discuss with my patients that I notice, and it is very common during this time where cycles are being skipped or even heavy cycles are occurring, it is because the estrogen outweighs the progesterone. And as much as everyone may think about hot flashes, which is a sign of low estrogen, it is really the drop in progesterone during the perimenopause that drives a lot of symptoms. And I will often replace or offer to replace progesterone first to help with sleep, to help with anxiety, to help with some of this cycle irregularity.
Yeah.
Wow. And you don't hear that often coming from all, kind of, I would say, conventionally trained gynecologists. So I applaud you for that because I'm not going to put anyone on blast, but I have had to ditch one of my doctors because I kind of felt the way that what you're describing now, I felt that maybe what I'm dealing with was progesterone, and I was getting, it's the moment in time speech, even if we test it, we can't really trust these numbers. And So you do check
in perimenopause then. So one of the things you might do is put some on, get them on some progesterone. Is there anything else you would do in this situation to help with symptoms, lifestyle changes, other medications, maybe supplements, anything else you do?
Yes, absolutely. Many patients don't want to know from anything prescription. I want to go through this naturally. Well, there's tons of natural ways to go through it, and we can address hormone replacement later on. So most importantly, we talk about nutrition. Every woman, or many women, I shouldn't say every, many women are battling, trying to stay healthy and fit and keep their weight at a healthy level, not extreme one way or the other. Exercise. Eating healthy exercise promotes good sleep. There are certain supplements that will promote good sleep. Lifestyle as far as de-stressing and exercise such as yoga or meditation. I think all of these things can naturally balance our hormones, and women can get very good results from them.
And are you seeing that in the practice that the women, when you have the conversation, or maybe they're wanting to just try lifestyle first, do you see that there are noticeable improvements when they return to you?
I absolutely do. And I try to explain to my patients, it's really a spectrum. Number one, of how women go through the changes. And number two, how we treat it and how they treat it for themselves. So where I'll have an extreme patient come in that is having severe symptoms. And just from experience, I can recognize you need something more than some supplements to help you get through this period of time. And there's nothing wrong with that. And I spend a lot of time educating my patients on risks and benefits. And I get a lot of good results, which I'm happy to say. But I have plenty of patients who maybe their symptoms were milder, or even if they weren't, they go back and really try to address the sleep, the exercise, the nutrition, maybe some supplements. And they come back and say, I feel a lot better. Even a vitamin D deficiency can cause fatigue mid-afternoon, trouble sleeping. Vitamin D is responsible for mood, memory, bone health, preventing multiple or decreasing the risk of multiple cancers.
And that's something everybody can go on. Period.
I
I
know.
mean, that's like we're big vitamin D.
Yes.
It's a foundational nutrient, and well, it's a hormone as well. So it's a foundational thing.
I wanted to ask you about all that's fantastic, but some women, as you have said, have pretty severe symptoms during perimenopause. Some women, nothing. Everything's fine. How can you look at somebody, look at labs, look at their lifestyle, and say you're probably not having any perimenopausal symptoms? You probably are. Not that you would say it that way, but I'm just saying. Like,
I was thinking that. I didn't ask it, but I was wondering.
Is there a way to kind of know? Or have an understanding of why one woman nothing, another woman is having a hard time.
Yeah, what's the prototype for a woman of the woman who would typically have severe menopausal symptoms versus that woman who like they're going through and just everything's okay.
I have to say,
Very
I don't
smooth.
have a prototype.
Okay.
It's really different.
Like you wonder,
It's a
like
very individual, very individual
Yeah.
process. And if I have to say something, I've seen, it's hard to explain. Some of the women who go through the roughest changes are the ones who never expected it. Like, what is happening to me?
Wow.
You know, I am an executive of a company. And
then that makes me think stress.
and it could be
Right,
related to
you know.
stress. Maybe that is something, but I usually don't think prototype.
Yeah.
I look at everyone as a clean slate.
Okay.
Like I said, there's a spectrum of how everyone goes through it.
Right. No
I
diet.
don't try
like
to
vegetarians versus. Do you see any
I
changes
don't
there?
I don't dig that deep.
Okay.
I don't.
All right.
I don't.
Well, you see certain cultures where menopause is a non-issue, and so that's what makes you think. Like sometimes is that lifestyle factor, and I think you kind of answered that question with how
I just brought it up,
Yeah.
and that's for your answer is great. I think that's great. I just brought it because I have 3 sisters. And they've all gone through. They're all at postmenopause now. 2 of them, nothing. They were perfectly fine, no change, no nothing. My another sister though, horrible for many years.
Wow,
horrible symptoms, and they similar lifestyle, similar everything.
Yeah.
You know, they even look alike. You know, it's like. So I'm I was just curious.
I think that's very accurate. I've experienced that myself.
Yeah.
Well, I think it goes back to the fact that we're all individuals, and that's the beauty of kind of personalized medicine as well. That when a person comes in and having a doctor that treats you as you and not try to apply a cookie cutter approach.
How do you approach hormone therapy when you look at everything and you're like, okay, it's time for us to sit down and talk about this? How do you approach that? What are some of the common ways you replace estrogen? Progesterone? Do you use creams, like how do you approach all that?
And even testosterone.
Testosterone too.
Yeah.
So
So I first explain. So we've already established that this patient is interested in hormone replacement therapy.
Yeah.
So I start off with there are 2 types of hormone replacement therapy. There are synthetic hormones commercially made. There are compounded hormones. I do ask them if they've done any research or have anything in mind, because I could, talk for an hour to each patient, and that's not practical. Right. So if I feel they're leaning one way to the other, I try to tailor the conversation that way. But basically, I start off telling them there's 2 different types of medication or hormone replacement. The American College of OBGYN and a lot of the authorities do really feel that the synthetically made hormones that we get at Walgreens and Publix and Costco are really just as effective. They're FDA approved, they're monitored, and they are affordable with an insurance copay. Whereas compounding, although I feel the safety profile of both are equal, I feel that they're both equally effective. The compounding hormones right now are really out of pocket.
A little more expensive.
So that can be a lot for a patient, but the beauty of the compounded is that we can tailor it to a patient's needs a little more tightly
Mm-hmm.
than maybe the doses that we have offered at Walgreens.
Yeah.
However, there's plenty of doses. So what I have learned and established is my first line of treatment is a transdermal estrogen. Initially, we were always looking at the black box warning of estrogen
That's
being,
gone.
and I don't
Yeah.
really want to get into that right now.
We've talked about that.
We
before.
have.
Yeah.
I still feel like the safety profile is there.
Yeah.
The benefits are here. The risks are here. Obviously, to the individual, it's still going to be a very specific conversation. But just speaking about estrogen, I have just gravitated to using a transdermal. If it works, great. If it doesn't, we go to oral. Progesterone, again, we can get progesterone from a compounding pharmacy. We can't get it from a regular pharmacy. So I will choose to use a micronized progesterone from a regular pharmacy. Sometimes that's not tolerated. We have to go to a progestin, which is a synthetic version.
Yeah. Yeah.
As far as testosterone, there's really the medical community has not established a universal standard for women to receive testosterone. We know when the ovary doesn't work anymore or doesn't produce hormones that estrogen, progesterone, and testosterone are at really low levels. The adrenal glands can produce a little bit of testosterone. But nevertheless, the only commercially made testosterone is geared towards men. It's very, very strong. I'm a very low and slow provider of hormone therapy.
Okay.
I don't do the pellets in my office. I do recognize when I think a patient would benefit and I refer them out.
Yeah.
But pellets are its own story, it's
Right.
its own procedure, and it's just not something
not
I
something you
had
do. Yeah, that's
done in
fine.
my
Yeah.
office. So I will lean towards the compounding pharmacy for that. And there's lots of different options for testosterone. There's a low dose cream. There are troches, which are sucking candies.
Right.
There are rapid dissolving tablets. And I don't know if I mentioned the cream.
Yeah.
There's suppositories, and there's lots of different ways to administer that. And once I see that doses go up, and maybe we're not getting the effect we're looking for, then I will say maybe we should look into injections
Or
or a
something
pellet.
else,
And
yeah.
I have referring physicians.
A couple of follow-up questions to that. So when you look at all these different options for delivery, right? I mean, you just mentioned a whole bunch. Do you feel like absorption, bioavailability is all equal in these different modes of delivery? Or do you prefer a gel over a cream or the pad?
It's up to the individual.
Okay.
There are some women who say, oh, I don't want to wear that patch. I'd rather take a pill at night or during the day. I don't like the cream. I mean,
So you work-
again,
you
it's
gotta work
very
with-
individual.
And how often are you testing? Like, what's your testing strategy?
Okay, so I do a baseline of hormones just because I think it's good to get a baseline.
Agreed.
And especially if we ultimately do want to add testosterone to the story, I want to know where we started.
Oh, yes.
But again, there's no standards, which is, it's good and bad. I think the safety profile is there, so I'm not overly worried about it. I don't want to see a woman's testosterone level be as high as maybe a male's testosterone hormone. I don't know if that's necessary. I really don't have a list of risks of testosterone. But again, my philosophy is always low and slow. And what I have found is that a low dose goes a long way.
Yeah.
So if a woman is using a patch and a progesterone and there is no testosterone involved right now, and we are getting that, let's say, from a commercial pharmacy, technically there's no reason to keep checking the hormones as frequently, especially if she's feeling great.
Yeah.
If she comes in and says, my breasts hurt, well, then I know we better back down
Right.
that estrogen.
Back up,
If
yeah.
she's having tremendous acne after using testosterone and her hair's
it
thinning,
down.
well, I'm going to get that blood level and try to see what's going on there. Now, if I do have someone using compounded hormones, I will check them more often, maybe every 3 to 4 months.
Okay.
Because like I said, there's different absorption rates, there's different modes of taking the hormones, the compounded hormones, and I just want to make sure we're in a good range. Again, I don't want a woman maybe to have a level of 200 of estrogen. What I find with that is maybe some bloating, some breast tenderness. They can even create ovarian cysts. So I do watch that a little bit. I don't see those levels skyrocket as much with the commercial patches. And
So when you offer the choice or you have a discussion between the synthetic hormones versus the bioidentical compounded, what do your patients tend to choose?
both.
It's pretty equal overall.
Well, I would say it's a tad more of the commercial, and a lot of it is financial. But it's with my population of patients, I'm about 50-50.
But just correct me if I'm wrong, though. With the commercial option, there are bioidentical estrogens that's available through a commercial. Like
Right,
can you clarify that, please?
I think the word bioidentical has a lot of definition. So ideally, yes.
Okay.
An estradiol patch is created to mimic the estradiol that our ovaries are not making anymore, as opposed to, let's say, a birth control pill that has ethinyl estradiol, which is completely a synthetic hormone, which is terrific and has great function in our world.
Mm-hmm.
So yes, we technically can say
Or biosimilar, maybe.
Biosimilar.
Well, that is a
I
word
like
that's
that
being
language.
used more.
Yeah, that it's-
biosimilar.
The way I was taught is that the bioidentical hormones are from the compounded pharmacy because they're just made with less preservatives and a different chemical composition. But essentially, I feel risks and benefits are very similar.
I don't know. In the old day, we used to just if on the prescription, if it said the name, if it said estradiol, it's
That's
bioidentical.
estradiol,
Yeah.
right.
If it says testosterone, it's testosterone, and you would assume that's bioidentical. And
or progesterone.
Or progesterone. Yeah.
Then you
so-
know
As
that
opposed to
you're
a progestin.
Right.
Yeah.
Yeah.
So
Yeah.
we used to just look at the name. You know, that's how we figured it out. Yeah. So when you're seeing all these patients, by the way, how many patients do you see a day? Just curious.
So I average about 25 a day.
Yeah.
Yeah. Sometimes it creeps up to 28.
Well, I think that's actually pretty
I like
good.
25
Yeah.
because I really do give my patients a lot of time. And if any of them are watching, they know that I tend to run late sometimes. But I give a lot. I try to really give everybody what they need. And I love doing it. So it comes out easy.
Yes.
And then I hear it tap, tap, tap on my door because I'm running a little bit
It's
late.
time to
but-
go.
Yeah.
Yeah. Well, what about when you're seeing all the patients and you're having all these discussions and stuff? Are there any issues that you think are overlooked in these conversations that you have with patients? Like, are there things that patients don't even think about in the perimenopause, menopause phase that you like to bring up?
Yes. So if I start with some general questioning about cycles or how you're feeling, many women are like, I feel great. I don't have a hot flash. I feel great. So there are two things that I feel very strongly about that I kind of really try to drive home. One is vaginal health and two is bone health. And those things can really start affecting women certainly early in the 40s. We know bone health can change as early as our 30s. So these are things that you don't see.
Right.
And they are so number one, no one sees their bone health. So no one's getting bone densities at 35 or even 45 either. So I try to drive home, let's remember our bones. Let's remember calcium and vitamin D. Try to get even calcium from your diet is just as important, and weight-bearing exercise.
Yeah, very good.
Because when
weight bearing, very good. We're big on that.
weight-bearing.
Yeah.
And then vaginal health is just huge. It's very overlooked, and it's not until sometimes a year or so after a woman is fully in menopause, sleeping well again, no more hot flashes, decided not to do hormone therapy, and they're like, shop is closed. It is really dry down there.
Yes.
It kills me. I can't have relations. Or I keep getting bladder infections. And so this is huge, huge, huge. I feel very strongly about it. I really do dive into the importance of estrogen and vaginal health and bladder health.
Do you prescribe a vaginal estrogen? Or-
Almost 50 times a day.
Okay.
Yes.
Oh, so you're
Okay,
doing
yeah.
that a lot? Okay. Okay.
Absolutely. And we know even before this whole black box thing changed, very low risk. It gets absorbed locally.
Right.
And when serum levels are checked, there's nothing there from using vaginal estrogen. Now, there's a lot of other products that are very good. And you have a patient who's going through active breast cancer therapy,
They
whichever
can't
it
do
is.
that.
And even if their surgeon says it's safe, they're going to be shy about it. I can't blame them, of
Yeah.
course. So we have lots of alternatives. There are products with hyaluronic acid.
Yeah.
There are products, coconut oil. There are
Right.
many things that can help maintain vaginal health, but it is very important to address.
Yeah, but
Yeah,
I would
so
have to assume
just-
the estrogen is the most effective.
It is because the tissue is responsive to estrogen and the bladder likes estrogen too.
Right. Right.
So with the anatomy, the urethra is very close to the vaginal canal, and there's just a lot of overlap there.
So this is an off question, and you don't have to. It's on topic though. So that because there is this new idea, and the reason I asked about that, and I'm happy you brought it up, is the vaginal moisturizers now, and there's this. On the internet, Google land now is saying that women should use a vaginal moisturizer regularly, regardless if you're in menopause or not, that this is just something that just like we moisturize our face, that you should be using a vaginal moisturizer. And so what do you think about that?
So I actually think that's a terrific idea because with our younger women, anyone on a hormonal contraception has a risk of having vaginal dryness.
Okay.
And vaginal dryness promotes more issues with vaginal infections, even if it's a yeast infection. I'm not familiar with what's in the vaginal moisturizer you're discussing. I've seen many on
Mainly aloe based is what I'm seeing.
So
So
aloe
this
base
is
is great, but
non-estrogen
Not,
creams
but
or
it's the same idea.
something.
Like for someone who maybe they don't want the estrogen.
Okay.
but there's a couple advertised, and I dig
okay.
into it. I do that scrolling into it deeper. I want to know what the ingredients
Yes.
are, and we'll find out that it does have estriol or some type of hormone in it. So now that is still not going to be given out nilly-willy.
Right.
You probably need a prescription or a telehealth visit for that prescription. If it is truly something with aloe, hyaluronic acid, vitamin E, coconut oil, well, that's truly
Yeah.
Or is it
benign.
possible that maybe if there is some estradiol in it, as an example, right, that if it's at such a low percent, it is over the counter, or is all estradiol has to be
No,
prescription?
there are a couple of items over the counter. There is a cream that has a low dose progesterone in it over the counter, and there is definitely a cream
I've
that
seen
has
those.
an
So
estradiol over
there's
the
like a
counter.
So you have to
percent.
look at. I think the takeaway message here is make sure you look at that label.
The label, yeah.
Yeah.
Absolutely.
I'm going to go way back to the beginning of this interview. You're doing a great job.
I know.
Thank
We're having
you.
so much
It's like,
fun with
I
you.
know
Thank
I just
you.
want to keep you here all
I know.
day.
No, I mean this has been you're doing this is fantastic. So we'll go way back to the beginning where you mentioned one of the things that you do is you test thyroid, right? And how
Yes.
important that is. How often do you find women in that 40 to 50 age group with some low functioning thyroid? Maybe not overt hypothyroidism, but that subclinical maybe. They have some symptoms, but their labs aren't so bad. How often do you see this?
Average, maybe 25% of the time.
So it's not here. Okay.
It's
Okay.
not. It's,
It's
not.
not
I kind of
huge.
felt like it was going to be a lot higher than that.
No, it's not huge. I have a little so I do test for it. I don't necessarily treat it, but I do know it's an important connection to how the menstrual cycle and the menopause is going. So I will do the basic testing, maybe beyond what many family practitioners might do. I do check for thyroid antibodies.
Okay.
Oh, okay.
I have a little familiarity with the autoimmune Graves' disease and Hashimoto's. My sisters both have experienced it. So I became very sensitive to that, and I test everyone. So then I have a little bit I can discuss. I tend to not want to treat, but unfortunately, it's very hard to get in with a good endocrinologist lately. So if I feel comfortable enough that it's a benign meaning I'm not looking at nodules or a huge goiter or something that's really out of my lane, I might start the patient on a low dose thyroid medication just to have them, especially if they're having tremendous symptoms.
Yeah.
If it's, you can have positive antibodies and still have a euthyroid functioning absolutely normally at this moment. So I make them aware. I urge them to maybe do a little bit of research about different things that can help an autoimmune problem. It's everything's about inflammation and sugar and gluten, and that's a whole different category. But some of that information's out there. But at least then they have this information to go to their primary physician or a specialist and say, hey, this came up.
So I have one more question, Dr. Mike. And this relates to the perimenopause, menopause years. You talked about bone health. Can you just briefly talk about the importance of mammograms, especially if you are thinking about hormone replacement therapy?
Yes. So I think the safety profile for mammograms is there. I've never been concerned with too much radiation or having it increase the risk of breast cancer. But unfortunately, breast cancer is a huge epidemic in our world right now. And I basically will tell my patients, if you don't have a mammogram, you're not getting any hormones. And that's the end of the story.
I love it. I love that.
We used to do our baseline mammogram at 35. That was moved up to 40. Probably should be moved back to 35. I know that sometimes when the breasts are too dense, we're not going to get an accurate reading. Things may get overread. But there's a lot of breast cancer in our world right now. Now, again, I do feel the safety profile and the benefits of hormones are here. The risk of it causing breast cancer is here. But nevertheless, if God forbid someone had something that we weren't aware of, and I'm like, here's your hormones, poof, that's a problem.
I don't think it's hormones causing a cancer. I think it's pretty well established, even in prostate now, that that's not the case.
But if it's there, it can aggravate
if there's
it.
something there,
Yes.
sure, because they that's their fuel.
Exactly.
Right.
Yes.
So it's a different story though.
Well, I love that approach. It saved my cousin's life because her doctor was thinking about, she was having really bad hot flashes, and her gynecologist said, okay, well, before we go down this path, I'm sending you for a mammogram, and they found breast cancer.
See, yeah.
So, we say, well, the high flashes that allowed her to catch a very early stage. And so we're just thankful for that and thankful for all the work that you do.
Thank you.
You're listening
welcome.
to Dr. Michelle Lapioker. She's been practicing since 1995 in South Florida, right next door to Dr. Crystal, all these years. Is there any last word you have for the listening audience about perimenopause, menopause? Anything else you want to share?
Don't be afraid to talk to your physician about things that are bothering you. The vaginal health is hard to bring up, but bring it up. If it's bothering you, bring it up, because it can change so many things in your personal life. I think it's important to get educated. I think fortunately and unfortunately, there's a lot of information out there. I think it's important for patients to be educated. I'm a little frustrated with some of the challenges I have recently with, AI said.
Oh, no.
And
That's going to get worse.
I understand that, and I try to be respectful about that. I've taken lots of courses, though, on hormone replacement therapy. I've been practicing for 30 years.
Yeah.
I trained for, 4 or 5 years in my specialty. So I keep up with the basis. So I think that patients should speak to their physicians. If they're not getting the right answers or answers that make them feel comfortable, then find another physician.
Fine. Sure. Yeah.
I think that the questions can be asked early. That's important. And I guess that's
fantastic.
That's my biggest.
Does your practice have a name?
Lovely Lady GYN.
I didn't know that.
Lovely
And I do
Lady
have a
GYN.
website.
And what's the website?
www.lovelyladygyn.com.
There you go. We'll have that on the screen and everything, hopefully. So if you're interested, give Dr. Michelle a call. That'd be fantastic.
Thank you.
You did a great job. Thanks for
Yes.
coming
Thank
on.
you. appreciate it.
I loved being here. Thank you for having me. I'd love to come back and talk about something else.
Oh, yeah. That's already,
it's
already
done.
done deal. Yeah.
Or more menopause,
Yeah.
because everybody wants to talk about menopause. It's fine.
Don't forget, you can go to liveforeverest.com, Dr. Crystal, and not only review this episode again and like it and share it and comment
Save
and
it.
review it and save it, all that, but there's tons of other episodes. I am very confident in that library there's something, probably a bunch of episodes you would love to watch. So check that out at liveforeverest.com. And then our sponsor, Dr. Crystal, wants to say,
Thank you.
with a discount code.
Podcast. So you can head over to lifeextension.com, look around, and if you add a few things to your cart, use the discount code podcast to receive 10% off $50 or more, plus free shipping and handling.
I'm Dr. Mike. That's
Dr. Crystal.
Thanks for listening.